So hello everyone, today we'll be discussing a very important topic for the examination as well as for reporting basis of pancreatic carcinoma, that is the resectability criteria. This is very important for the clinicians or the surgeons to know whether the pancreatic lesion is actually resectable, borderline resectable or unresectable, whether they have to do a Whipple's procedure or an extended procedure and how they have to proceed. So this particularly, the resectability is usually assessed by the radiologists on a cross-sectional imaging, particularly the contrast enhanced CT scan, and for that we need a protocol, the pancreatic protocol, which includes a late arterial phase and a portovenous phase. So what exactly do we assess in late arterial phase? So late arterial phase is done 15 to 20 seconds post contrast with an injection speed of 5 ml per second, and the normal pancreatic parenchyma shows enhancement in this particular phase, whereas the most common neoplasm of the pancreas, malignant neoplasm of the pancreas, that is the adenocarcinoma of the pancreas, is hypoenhancing in this particular phase, and that is how we actually diagnose adenocarcinoma of the pancreas. And with that, arterial anatomy, particularly the replaced hepatic artery or accessory hepatic artery arising from the SMA, can be assessed in the vicinity of the tumor, and also their invasion, whether the artery has been is abutting, whether the tumor is abutting the artery or invading the artery, can be easily assessed in arterial phase. In portovenous phase, which is actually 60 seconds post contrast, there is enhancement of other organs, particularly liver. For METs, we have to assess the liver parenchyma, and we also look at the venous anatomy here, whether the veins are in normal shape or oval shape, or whether there is abutment or encasement of the veins. So pancreatic ductal adenocarcinoma is the most common malignant neoplasm of the pancreas and is very aggressive, with particularly delayed presentation when the lesions are in the body and the tail region of pancreas, because head lesions will usually present with obstructive jaundice earlier. Complete resection of the tumor is the only curative treatment, which is not possible in 80% of the cases, because 40% of the cases at the time of presentation will have distant METs, and the rest 40 will present with a locally advanced pancreatic carcinoma, which is usually unresectable. So resectability mainly is determined by four major criteria. When we think of resectability criteria for pancreatic carcinoma, we usually think of NCCN criteria and the critical vascular structures. But we have to keep in mind that there are four major criteria, and we have to assess all four of them, not only the NCCN criteria for vascular invasion. The four important status determining criteria are: one is the size of the tumor, which is the longest diameter in the axial planes. Second is the vascular structures, which is the most important NCCN criteria. Third is the invasion of the nearby adjacent structures like transverse mesocolon, root of mesentery, and perineural invasion. And fourth is the lymph node involvement, whether it's locoregional or extra-regional lymph nodes. So accordingly, the carcinomas can be categorized as resectable, borderline resectable, or unresectable. So size, vascular structures, invasion of nearby structures, and lymph nodes. Size, vascular structures, invasion of nearby structures, and lymph nodes. All the four are very important. Please remember it. So coming to the most important criteria for resectability, that is the vascular involvement, which is given by NCCN, that is National Comprehensive Cancer Network. We need to know certain general rules for vascular invasion. That is, what is abutment and what is encasement of a vessel. So when the tumor involves the vessel with less than 180 degrees contact or up to 180 degree contact, it's called abutment of that particular vessel. When the tumor has more than 180 degree contact with that particular vessel, then it's called encasement of that vessel. So why is it important? So encasement of the vessels has a higher probability of invasion compared to abutment. And in case of venous involvement, the length of invasion is also very important, because it helps guiding the surgeon how much length of the graft has to be placed. And if the length is too much, the involvement is too much, then it becomes unresectable, because that graft cannot be grafted. So length of venous involvement is important, and degree of involvement of vessels is important to understand whether the vessel is abutted or encased by the tumor. So other than encasement and abutment, there are certain morphological changes in the vessel that also suggest vascular invasion. So even if the tumor involves less than 180 degrees or up to 180 degrees, but has wall irregularity, that is, wall irregularity is seen in the vessel, especially in the arteries which have a thicker wall, then it is suggestive of invasion of that particular vessel. Then there is a teardrop sign, particularly in the veins, when there is a change in the shape of the SMV or the portal vein from oval to round to a teardrop, which is caused by tumor encasement or tethering by adjacent fibrosis, then it is suggestive of vascular invasion. And the third important feature is thrombosis within the vessel. If there is thrombus within the vessel, then it is suggestive of vascular invasion. So all these three important morphological changes are also suggestive of vascular invasion other than abutment and encasement. So these include wall irregularity, teardrop sign and thrombosis. Wall irregularity, teardrop sign and thrombosis. So all these things can be assessed properly on the multiplanar reconstructions of the CT, in which all the planes will be seen and all the vessels can be easily seen for any features of invasion. So according to the resectability criteria, the tumors can be divided into resectable, borderline resectable and unresectable. Out of this, the borderline resectable is the most confusing and the vascular criteria is the most confusing in borderline resectable. So we are going to discuss that first so that the confusion is solved. So borderline resectable will divide into arterial and venous. So in artery, if the artery is involved less than 180 degrees or up to 180 degrees by the tumor, particularly the common hepatic artery, the SMA or the celiac artery. When the common hepatic artery abutment is present, but it does not extend to the celiac artery or bifurcation of the common hepatic artery, or the solid tumor contact is there along with variant anatomy like accessory hepatic artery or replaced hepatic artery, or when there is, now this is an important thing because it's a recent advancement, when the celiac artery has more than 180 degrees contact, that is, it has it has been encased by the tumor, that is involved by the tumor, but the GDA is actually preserved, that is the gastroduodenal artery is preserved, we can still go for a modified Appleby procedure because the GDA will have some retrograde collaterals which will supply the liver parenchyma. Then in venous, if there is encasement of the veins, that is the portal vein or SMV, but up to a particular length which can be surgically reconstructed, it can again be resected. So in artery, usually we say abutment, up to abutment is usually resectable, borderline resectable. Encasement of the celiac trunk is particularly now being considered borderline resectable because of the modified Appleby procedure. But in veins, usually encasement is also considered to be resectable up to a particular length. Then the tumor contact with the IVC can also be resected up to a particular length. So these are the variant anatomies that are present along with the percentage of incidence that we encounter on our daily practice. So most common out of this is the replaced right hepatic artery. So accessory right hepatic artery or replaced right hepatic artery usually arise from the SMA, the superior mesenteric artery, and in accessory right hepatic artery, it's just an accessory artery along with the right proper hepatic artery, but in replaced right hepatic artery, it is the only artery that is present for the right lobe. Then accessory left hepatic artery arises in the left gastric artery, and same goes for the replaced left hepatic artery. So then coming to another important criteria for resectability, that is invasion of the nearby structures. So some structures which are present in the vicinity of the tumor like duodenal invasion do not preclude resection because it is usually taken out in Whipple's procedure. But gastric invasion is definitely suggestive of unresectability. Then other structures like perineural invasion, transverse mesocolon, root of mesentery are commonly overlooked, which usually warrant an extended resection or even lead to unresectability. Coming to perineural invasion, the perineural spread is a very common finding in pancreatic adenocarcinoma. It is seen in more than half of the cases. And it is a very important factor, prognostic factor for early recurrence and metastatic disease. And usually when we hear the term nerve, we usually think of MRI. But on CT, we can definitely assess this perineural invasion and we have to, or we should put it in our reports. And how is it detected? It is detected by seeing an infiltrating soft tissue from the edge of the tumor along known specific peripancreatic neural pathways, that is along the celiac trunk or the SMA, and it is usually from the head of the pancreas that this perineural invasion occurs. Even the small tumors can show perineural invasion and lead to unresectability. So this is a very important thing that we should assess and put it in our reports, which we commonly miss. So these are the neural pathways, the celiac plexus as well as the celiac ganglion and the nerves along the SMA. And the pancreatic head carcinoma can easily infiltrate along these paths and cause perineural invasion, which we should mention in our reports. On CT, this is how we assess. There is soft tissue around the celiac trunk as well as the SMA. We can see on this contrast enhanced CT, and it can that is indicative of perineural invasion, which we should mention because it has a very poor prognostic factor. Then coming to the route of mesentery. The route of small bowel mesentery extends obliquely in the abdomen, running from the ligament of Treat to the cecum. So how do we assess the spread to the root of mesentery? So this is particularly seen in case of carcinoma of the uncinate process. And the root of mesentery has SMA and SMV and with their predominant vascular structures. So the first jejunal branch of SMA and SMV serve the landmarks to identify this particular invasion. So if first jejunal branch of SMA and SMV are invaded, that particularly indicates spread to the root of mesentery. So if the invasion is limited, resection and reconstruction is possible, but more extensive resection, more extensive involvement is suggestive of irresectability. So here it shows the first jejunal branches which are actually involved with the soft tissue of the tumor, particularly the uncinate process of the pancreatic carcinoma shows this particular type of spread. Then comes the third important thing, that is the spread to the transverse mesocolon. So this particularly assessed by this one vessel, that is the gastrocolic trunk of Henle. So spread to the mesentery is assessed with the help of first jejunal branch of the SMA and SMV, while spread to the transverse mesocolon is assessed by the gastrocolic trunk of Henle. So the transverse mesocolon is in contact with the ventral side of the head of the pancreas and is usually invaded by the tumor of the pancreatic head, and it is identified on CT by following the middle colic vein and the right gastroepiploic vein to the point of joining to form the gastrocolic trunk, which is the last vein to drain to the SMV on the ventral side. So invasion of the transverse mesocolon does not necessarily preclude resection, but since additional hemicolectomy might be needed, it is an important information for the surgeons. So spread of mesocolon is assessed by gastrocolic trunk, and spread to the root of the mesentery is assessed by the first jejunal branch of SMA and SMV, and perineural invasion is assessed by seeing the soft tissue around the celiac trunk and SMA. Then there is a lymph node involvement. Lymph node involvement is another important criteria for resectability that we discussed, and it is important to discriminate between regional and extra-regional lymph nodes. The main extra-regional lymph nodes are the para-aortic and to the left of the SMA, and suspicious nodes in these locations should be documented and sampled. Lymph node mets are important prognostic factor, and they occur in approximately 2/3 of the patients with otherwise resectable pancreatic cancer. So these are the Japanese consensus diagram of the lymph nodes that are present, all the stations that are present, which includes all the regional and the extra-regional lymph nodes, and whether the surgery which surgery should be done according to the lymph node involvement. So this is the entire chart of whether the lesion is resectable, borderline resectable, or unresectable. Accordingly, everything is given. This is from the radiology assistant, which you can read.